So the class for today is acute and chronic pancreatitis, and our speaker is Dr. Anand Joshi, sir. He is a consultant intensivist and physician at Government Hospital, Hyderabad. So you may take over. Thank you.
Good evening, everybody, and thanks Farz Academy for giving me this opportunity. I believe this is more of a didactic lecture about one of the important topic, which as a medicine guys or any ICU specialist guys, you will soon you will be more than often encountering. And it is very important to understand the details of this topic, especially the acute and chronic pancreatitis, as the management is pretty simple, but it is more of not to do rather than what to do in these kind of situation. I'm Dr. Anand Joshi. I've got my general medicine background with DNB and FRCP. I've got my fellowships from India and Australia in intensive care. I practice in Hyderabad and in Sydney. So, coming straight to the topics of acute and chronic pancreatitis, we'll start with acute pancreatitis. It's itis, that is a pancreas itis. It's a simple, it's an inflammation. Itis means inflammation. Now, when the pancreas get inflamed, the inflammation comes from the enzymatic autodigestion. So all these enzymes which the pancreas is full of, they're so toxic that when they go in a wrong place, or if they get burst open or they get inflamed, it starts auto-digesting by themselves. More so often, the most common cause remains the biliary tract disease, almost 40 to 45%, with a very small gallstones which gets passed from the biliary tract and gets stuck into the biliary pancreatic duct and causing the backflush and refluxes of the enzymes and the biles and the juices that triggers this vicious cycle of inflammation and autodigestion. Alcohol also constitute about a major cause, almost 4 to the 20%, and both of them making it almost 60 to 70% as a common cause. There has been variation in the prevalence and the causes depending upon where you are, whether you are in India, whether you are in UK, US, Australia, or any other overseas, where the people have more alcohol intake, that it's likely that it might be more the reason. Obesity again would be contributing for the biliary tract gallstones, and of course not to forget the tropical pancreatitis, which we'll be seeing in Africa and Asia. The exact mechanism for this perpetual, what drives this inflammation and autodigestion, is still not clear. Sometimes it's just the edema or obstruction at the ampulla of water, reflux of bile into pancreatic ducts, or sometimes it might be a direct injury to the acinar cells by prematurely activated enzymes. These are the current hypotheses based on which we think that the pancreatitis and the perpetual inflammation of the pancreas happen. As I mentioned, biliary tract and heavy alcohol are the most common causes. The other causes, which many times missed, is the hyperlipidemia. Which we tend to ignore that, okay, it's just a high cholesterol, and we associate this high cholesterol or hyperlipidemia or dyslipidemia with our cardiac and stroke and vasculopathy, but we forget that it may be an important cause of pancreatitis. Other are hypercalcemia, abdominal trauma and the procedures. Yes, direct abdominal injury, even the blunt abdominal injury, road rage fights, kicking in the tummy, just sometimes if the car seat belts are also inappropriately placed, then a small accident of the car with the airbag may not have come up, but it just might have just torn apart your pancreas, and that might result in a pancreatitis. any procedure, endoscopic procedure, especially the procedures like ERCP, which say that it's a simple, it's a OPD procedure, but do carry a risk of having a pancreatitis because of the reflux. Cardiopulmonary bypass, because of the low blood flow, ischemia has been shown to have pancreatitis post-operatively. We sometimes get confused post-operatively because once the patient comes out of the bypass, goes into the intensive care, the patient was getting better, and then because the patient is sedated and he's on high opioids, the pain, he doesn't complain of the pain, but then it becomes suddenly goes into the surge response or a multi-organ failure, and we wonder why this is happening, and this more so we have to look for the pancreatitis. Single or double balloon enteroscopy is also a procedure, and that might lead to a pancreatitis, and we need to keep this thing in mind. Uh, More often than not, I strongly feel that we often ignore this aspect of medications. So medication-induced pancreatitis, simple medications like metronidazole, antibiotics, somebody's on valproic acid, somebody's on thiazide diuretic, some have taken NSAIDs, people are on simvastatin, fenofibrate, corticosteroid, and now the latest anti-diabetic drugs like sitagliptin, they all contribute as a cause for the pancreatitis, which we should keep in mind. Viral infections. Recently, we have seen a lot of cases of COVID in which we saw a few people getting a pancreatitis. We didn't find any specific cause, and it's been attributed now that it was because of the COVID. Mycobacterium avium intracellularly, which is again non-tuberculous mycobacteria as a cause. Hepatitis, mumps, cytomegalovirus, they are all can cause pancreatitis. Rarely, the scorpion bite poisoning can induce a pancreatitis. Besides all this acquired, we do have some congenital and genetic factor. Congenital and genetic factors, especially when the pancreas during the development has not, the ductal fusion has not happened, or in CFTR gene variants, that's a cystic fibrosis related gene, and same pancreatobiliary malunion. Certain cancers like pancreatic or ampullary neoplasm, pancreatic cyst, and celiac disease have also been attributed to acute and chronic pancreatitis. Despite all long list of pancreatitis, lot many times, especially in Indian subcontinent or in Asian subcontinent and African subcontinent, we may not know what is the cause of this pancreatitis, and that we call it as a truly an idiopathic in 15 to 25%. Even in this, it is postulated that a biliary microlithiasis, that's a very small stone which would have got stuck and then caused the pancreatitis and has passed on. So that again might be the reason. Sphincter of Oddi dysfunction, that is at the ampulla of Walter, maybe because of post ERCP, when we dissect the sphincter of Oddi, if it's a dysfunction. However, it's very, very unlikely because there is a lot of layers, but this is one of the cause that's been postulated. Besides these as a cause, there are few factors that will increase the risk of pancreatitis. That means if you already have these factors and if any of the trigger event happens, then the chances that you get pancreatitis because of this is very high. This is mainly the smoking, high glycemic load. Those people undergoing abdominal bariatric surgery, those are increased risk. Hello? Older age and obesity, as I mentioned. There are few factors that would be protective also. So vegetable consumption, high dietary fiber act as a protective thing. Even though simvastatin has been attributed, but use of other statins and regular coffee intakes have got an association with reduced non-biliary pancreatitis. I'm not talking about a biliary pancreatitis, but simvastatin by decreasing hypertriglyceridemia would indirectly be a protective factor. So how do these acute pancreatitis people present? We all know an acute severe epigastric pain, which is worse in the supine position. Now, why it's a worse in supine position? Because pancreas is more of a retroperitoneal organ, and when it is completely inflamed, it's the surrounding inflammation which it will relieve it will give the pain. It is relieved by leaning forward. So the retroperitoneal structure, when it comes back in front, it's more of like an hanging and it gets relieved. The pain radiates to the back, which again, the same reason, because pancreas is a retroperitoneal organ. Associated nausea, vomiting, and anxiety because it's not a good feeling. Because it's an inflammation, you'll be having this fever, tachycardia, hypotension, and distension of the abdomen. You will get it in severe cases, and this is particularly relevant as the pathophysiological aspect is the capillary leak which happens in pancreatitis. So the people are intravascularly depleted. All the water goes into the third space, and hence it causes a hypotension. Sometimes you might get palpable mass or epigastric tenderness if there has been recurring attacks or acute and chronic attacks because of the pseudocyst. Acute alcohol binge or even after a heavy meal may precede the acute abdominal attack. So there might be a trigger. There is some small amount of discomfort or inflammation is happening, and then somebody takes an acute alcohol on that, or takes a heavy meal, and then presents with an acute abdominal. Lab-wise, in the bloods, serum lipase and amylase, approximately like 3 times upper level of limit, are elevated. Now, if there is a pleural or ascitic, if the patient is having a pleural ascitic fluid, then they will have a very high amylase, and this is used as one of the criteria for the diagnosis, but not prognosis. Now, remember, amylase and lipase may get elevated in the other situations, which we will see in the next subsequent slide, but they are not specific only to the pancreatitis. So you have to have all the sign and symptoms as a pretest probability, and this may aid to your diagnosis. Inflammatory markers, mainly leukocytosis is seen. You can get a proteinuria, hyperglycemia, and elevated blood urea nitrogen. Serum alanine transaminase, that is SGPT, would be elevated. And if it's elevated, you have to look for biliary cause for the pancreatitis. We often fail to send this, but if you send the fasting triglyceride levels, and if it's very high, so more than 1,000 milligram per deciliter, then you can easily attribute that as a cause for the pancreatitis. Now, remember, when you are having such a high level of triglycerides, your amylase level may come as normal, and that can be a false negative, because when you're testing for the amylase level in the presence of high triglycerides, it gives a false negative results or a false normal level. So this is a point you need to keep in mind. Hypocalcemia because you can anybody who can tell me why hypocalcemia would occur? They can write in the box, or Fatima can tell me, or they can unmute and tell. Anyone? Hello.
It combines with fatty acids. It combines with fatty acids,
Any
which
specific?
are released.
Do you know what
Mm,
that word is called?
mm,
It's a
Saponification.
perfect
ah, sir.
for that.
Mhm.
Perfect. So that's a saponification would cause would to get the calcium adsorbed to it and cause a hypocalcemia to the level that the patient may end up having tetany. High creatinine, high hematocrit, high CRP probably would be associated more with severe pancreatitis, as I will subsequently tell why that would be. Now, this is pertaining mostly to the examiner's favorite questions if you're going for it. But also in the real world, you need to know or understand the severity. You need to know because in case of pancreatitis, the mortality is directly related to the severity. Now, the very famous severity scoring was the Ranson's criteria, but subsequently it was very getting hard to remember those things, and also it became very specific for pancreatitis. Other general severity scoring like SOFA scoring, Apache scoring came into it. Uh, Other bicep scoring or fast scoring or revised Atlanta classification came in, and everybody jumped in to give their own scoring system with variable mortality and variable accuracy. There is something called as harmless acute pancreatic score, that is the absence of rebound tenderness, a normal hematocrit value, and normal serum creatinine level predicts non-severe course of with almost 98% accuracy. So it would more of a negative predictive value kind of thing. So this is the Ranson's criteria. To be very honest, I had tried my best to memorize it over the years and would always forget the moment I come out of the examination hall. However, I keep it to the handy. Nowadays, we do have these things in the handy, and it does. It is still relevant. It is not completely irrelevant as far as even the theory is concerned. We can have a bit of a mortality rate based on the scoring system and the number of criteria has been made to 1:100%. As the criteria goes up, the mortality goes up. The bicep score, which I was talking about, is a little bit more simpler. You have blood urea nitrogen, impaired mental status, SIRS response, systemic inflammatory response syndrome, age, and the pleural effusion with 2 equal to 2 or more than 2 would get you to like 0.5 to 20% mortality. This one, revised Atlanta classification, classified it, the acute pancreatitis is mild, moderate, and severe, based on the organ failure at the time of presentation and associated local or systemic complication. So if it's a mild pancreatitis, you don't have any organ failure or any complications. But if it's a moderate or severe, then the organ failure system sets in. Now, if it gets resolved within 48 hours, it's a transient, then probably it's a moderate. And then if it's a severe, it's persist even after 2 days, then you are looking at the more severe acute pancreatitis. Now, the reason you need to know during the bedside is these people worsen over first week or so, and if in first 1 or 2 days everything is going fine and you know it's a pancreatitis, you keep the patient in an intensive care, you know the things are going to go bad, then you need to have a tool to explain it to the family, to your fellow colleagues, your gastroenterologist, or any other people, to tell that, guys, this guy has got this things. I think we should wait for 1 or 2 days and monitor him closely before we declare that he's doing well. So the reason you need to know or keep these criteria handy is not for anything else but to prognosticate the patient. It's not a thumb rule, it is always a fluid state, but you have to daily keep a vigil on the way which way the things are going. Imaging forms a very cornerstone when you are diagnosing an acute pancreatitis. When you do a plain radiograph, you will see what is classically called as colon cutoff signs. That is a colon. I don't have a picture, but I'm sure you will get it somewhere internet. You'll have a sentinel loop and a colon cutoff. It's a dilated loop essentially because of the severe inflammation of the pancreas. The colon gets into the ileus. CT scan more so often is the diagnostic. You will have a different, I will show you the various appearance and the scoring later. But you will have the changes in the pancreas, right from edematous or bulky pancreas to its necrosis to its complications. All of them can be clearly visibly seen in a CT scan, unless there are some technical issues or there is some non-virgin abdomen, or whether there is too much of gas. Then MRI becomes an alternative. But most of the time, it is the CT that will give you the results. Endoscopic ultrasound sometimes is used. However, it is main role is to detect the occult biliary disease that might be causing MRI as a cause for an MRI, rather than diagnosing the acute pancreatitis. Most of the time, it's a CT is enough. MRI, again, MRCP, when we use magnetic resonance cholangiopancreatography, again, it becomes a diagnostic. ERCP, its role is not for a diagnostic one, but maybe for the repeated idiopathic pancreatitis or associated jaundice is there. And it's clearly a biliary related pancreatitis, then probably it may act as a diagnostic and therapeutic. Now, based on the CT scan, again, there is a mortality prediction score, and it depends upon how badly the pancreas is involved. Now, just an enlargement of pancreas to the inflammation of the pancreas with the peripancreatic fat, or both, peripancreatic fluid collection, or peripancreatic multiple collections, depending upon that, you point them, and as the number of collections increases or inflammation increases, the additional points keeps going up associated with pancreatic necrosis, and the mortality estimation goes up. So it is the more the pancreas is damaged, the bad the prognosis is. Or rather, I would say you have to be more alert that this patient is going in multi-organ failure. Remember to keep the differential in your mind, especially when you are not very clear. The patient has come with an upper abdominal pain, severe nausea, vomiting, diarrhea. There is an upper abdominal tenderness. It can be perforated duodenal ulcer or acute cholecystitis. It can be intestinal obstruction. In all of them, you might get false high, lipase high. You may get amylase high. They may be non-specific, or it might be mesenteric ischemia or
ওইদিকে না ও আচ্ছা এই সামনেই আচ্ছা
Can you mute your, hello? Yeah.
Yes, sir, you may continue.
Yeah. So, you have to keep this differential in mind, because remember one thing, that if any perforated duodenal ulcer or any acute intestinal obstruction is missed, then the mortality is very high, especially if there is a perforation, because the treatment is not conservative. For acute pancreatitis, it is mainly the medical management, but for all these things, it is the surgical management. And if you delay that, then probably you have missed the bus and the patient is likely to die. So always keep your differentials very open. And it is okay to over diagnosticate these people, to rule out certain things rather than doing it under. Again, leaking aortic aneurysm, you can see it in the CT scan. As I said, serum amylase may be elevated in other conditions also, like mumps or ectopic pregnancy or any perforated duodenal ulcer. So be careful in diagnosing acute pancreatitis just based on the serum amylase and acute abdominal pain. So you have to keep this thing in mind. Let's look at the complications, because not only the bad pancreatitis is a cause for the high mortality, its complications are also equally bad. One of the important thing which you will encounter in acute severe pancreatitis or any kind of pancreatitis is a leakage of the fluids in pancreatic bed and LDS. Now, once you are intravascularly hypotensive, then you end up becoming a pre-renal azotemia or a pre-renal acute renal failure, with or without overt shock. So remember one thing, that it's not that the patient is in shock and the patient has got hypotension, and that is the worst case, and you will get renal failure with that. No, in case of pancreatitis, it is so bad that before overt shock comes in, the kidneys would already be could have stood up. Usually, it doesn't take long. Within 24 hours, the thing starts, azotemia starts, and it may last for almost 8 to 10 days, rather than uh, uh, it doesn't resolve so quickly. What I mean, and these patients, if not picked up early, and if the kidneys are not protected, uh, uh, they may end up requiring a renal replacement therapy. The second complication you have to look for, which is again bad, is the fluid collection and the necrosis. It can occur as early as first 4 weeks. Remember, on the first 1 week or 2 week, necrosis may not have set in, but maybe after 2 weeks, 3 weeks, depending upon how bad the severe attack is, it may come within the first 4 weeks, or chronically, if it has gone to the chronic phase, it may come after 4 weeks. So essentially, and across the spectrum, till the patient get discharged, or we have a convincing evidence of clinical improvement, necrosis can come hereditary. Now, remember, when this fluid collection occurs, or because of the leak or the necrosis occur, they get walled off with the fibers. And when you look into the CT scan or ultrasound, you will find it as a cyst. But because the wall of this is not because of any epithelial, it is not bounded by an epithelial, it is mainly because of the fibrous strands and the inflammatory things, which are the body's natural response to contain those fluids at one place. We call it as a pseudocyst rather than a cyst. And these pseudocysts have got all the debris, they have got all the proteinaceous secretion. And when you have all these things, they become a very good place, medium for infection and organism to thrive. And when you get into that, these get into a secondary complications of having been infected or infected necrotizing pancreatitis. and this can happen in 5 to 10% of cases. It's extremely difficult to differentiate between a pure inflammatory things, inflammatory collection versus an infected inflammatory collection. And unless and until it is always a debatable, even despite lot many things, unless there is an absolute an organism has grown, it becomes very difficult to say whether it's uh, a sterile inflammation or an infected inflammation. Pancreatic necrosis, it's a big thing because the mortality is very high. Bigger the necrosis, the higher the mortality, or these people eventually end up with the morbidity because of they end up going in a chronic pancreatitis and its related complications. Uh, it is again very hard to diagnose that this is because of pancreatic necrosis, whether this is a sterile inflammation again with the necrosis, or there has been a secondary infection. This comes typically with again fever, leukocytosis, and shock. So the patient is already sick. They have been fluid resuscitated. It shows a bit of an improvement, but then again starts going down. Now, whether that is an ongoing pancreatitis, whether there is a secondary infection, or whether this has become a pancreatic necrosis, it becomes very difficult to find out. Even on the CT scan, if there is a lot of pancreatic necrosis happening, whether that is the reason for its deterioration, becomes a very challenging for the diagnosis. These pancreatic widespread necrosis again get into the vicious cycle of inflammation and organ failure, may end up with a GI bleeding, may end up with respiratory failure and ARDS and multi-organ failure, including the AKI. One of the pathophysiology they have the books have mentioned, or the gastroenterology people mentioned, is that the pancreatic duct, which is gets highly inflamed and gets necrosed, may get disconnected, and again the pancreatic juice will keep on leaking from there. So this is called as pancreatic duct syndrome. It's a very bad thing to happen, and it is extremely challenging for all the gastroenterologists, intervention radiologists, and the intensivists to manage this patient. Whenever you have this connection or pancreatic necrosis, no surgeon will be happy to go in unless it is extremely indicated. Nowadays, we need to first demonstrate whether there is any infection or not, and the CT guided aspiration has become a very promising procedure in this kind of scenario. ARDS, as I mentioned, is another complication of acute severe pancreatitis. It usually occurs as a part of inflammatory response. These people are typically been resuscitated with large volume fluid. So and as a part of the whole organ failure and SIRS response, the lung get involved and end up with a respiratory distress. These people more often require an intubation and mechanical ventilation because of their hypoxia. Pancreatic abscess, it's a suppurative process, usually occurs 6 or more weeks after the onset. So you can easily say that pancreatic fluid collection to pancreatic necrosis to pancreatic abscess, these are on the worsening spectrum of the disease, local disease process. So you can say that once it gets infected, it becomes a pancreatic abscess, and once the infection is there, then there is a bit more of an inflammation, more generalized involvement of the organ failure system, and more so often the patient may end up with a left-sided pleural effusion or splenic vein thrombosis. However, if the only difference from the pancreatic necrosis is that when you drain this abscess and give an appropriate antibiotic, then there are high chances that the patient recovery is faster, and requires, hence this called as, they are known for the low mortality rate after drainage. As I mentioned, pseudocysts are the another ones, encapsulated fluid collections. If they're very small, nobody bothers and you don't need to touch them. So you have to just resolve it spontaneously. And they may occur at the multiple place, or they may occur at the multiple anatomical planes. If they get infected, then only you need to you need to drain it. But otherwise, you don't need to touch them. They resolve themselves. This is something which is quite tricky. Now, pancreatic ascites occurs as a part of an inflammatory response of the generalized abdomen. And when this happens, it becomes very difficult, especially if the patient has got a cirrhosis or a renal failure. One of the way you can find out whether this ascites or whether this fluid is a part.
Doctor?
Dr. Mahavadi.
Sorry.
Yeah. So when this one of the ways you can find out whether this this collection fluid or ascites is pancreatic origin, for that matter, even the pleural effusion, if you are suspected, send the amylase. If the amylase is extremely high, then you can say that this is the source of this, or the cause for this pleural effusion or ascites is from the pancreas, or it is a complication of the acute pancreatitis. Because this one of the hypothesis is it results from the pancreatic duct disruption, and as a part of acute inflammatory response, you get this ascites or pleural effusion. Other rare but potential lethal complications you can get with the severe necrosis will be hemorrhages of the vessels, and it's a disaster, to be very honest. The mortality is extremely high, very difficult to know. The whole abdomen is filled of blood, and it is a very nightmare. Requires immediate surgical intervention. Mortality is extremely high. Colonic necrosis, venous thrombosis because of the high inflammation is another thing. Abdominal compartment syndrome, intestinal ischemia, and gastric distension or gastric outlet obstruction are one of the important complications which you will come across if the patient is intubated, ventilated, multi-organ failure, and in intensive care unit. This is one of the very important intensive care unit problems which needs to be tackled and require a CRRT. If everything the patient survives from, in case of acute severe pancreatitis, a very bad complicated pancreas survive, these people more so often end up getting into a chronic phase of chronic pancreatitis, and diabetes mellitus almost in 10% of the cases. Coming to the management, this is mainly classified as mild or severe disease and managing its complications. Sorry for the busy slide, but there is a lot in this, and I'll try to squeeze it. If it's a mild disease, it typically resolves spontaneously within the days. You just have to take care of that. You don't stimulate the pancreas. You have to take care of the pain. You have to give them nil per oral, give them a good bed rest, putting a nasogastric tube and trying to suck out all the juices, secretory juices, will be very, very beneficial. Early signs of if the patient is hemodynamically stable, don't get fooled by it. Try to be very cautious regarding the fluid management. Now, you will come across there are different strategies. There is no single strategy or proven therapy to say this is how and this is what the fluids need to be given. Early aggressive fluid resuscitation is what I'll talk about, but there is no one way or one method to resuscitate this patient. The way I tell the people is you be to the bedside, assess your intravascular volume status. There are different tools, right from CVP to ultrasound induced use of ultrasound for the IVC, collapsibility, then pulse pressure variation, you name it, and there are different ways to look at it. Use any of the one method which you are comfortable with and resuscitate the fluid, resuscitate the patient with whichever fluid which you want. There are no fluid has shown any superiority of one over another. This is one of the regime they have said is give 1/3 of 72-hour fluid volume in first 24 hours. Then you again continue with 250 to 500 mils an hour. Lingers lactate solution is preferred over normal saline. These things are different strategy. One of the strategies of the many strategy which you can. In fact, I would say there is no strategy. It is all tailor made for individual patient. Uh, However, one thing is common and sure in this: you need to give fluids. You can't starve that person. You cannot starve that kidneys, and you have to be very careful in giving the fluids. But you have to give fluids. That is for sure. The second important thing is a pain management. Opioids are always preferred on that. It gives a very good pain relief, whether you use a fentanyl PCA or whether you use a tramadol PCA or whether you intermittent. Oral, if patient can tolerate, that's okay. But most of the time you want to give initial days a bit of a rest to tummy and pancreas. So rather IV and subcut is preferable. Remember not to starve these people for very long. Try to gradually reintroduce the oral intake. Sometimes people gets very stretched, and if it's just a mild disease, and the patients, one of the early signs would be the patient starts feeling hungry. And once he starts feeling hungry, don't go for complete biryani or full halim on the day one. Just give him a bit of a clear fluid, and remember to give some low fat diet. Try to give him the things which are very gentle, non-spicy, and see how he behaves, and then gradually increase it. If the cause of this pancreatitis is known, that is a post-acute biliary pancreatitis, then laparoscopic cholecystectomy during the same admission or endoscopic MRCP is indicated. If this pancreatitis is recurrent and it's because of some congenital thing, then probably a stenting or sphincterotomy may be considered. When this is because of the hypertriglyceridemia, when your triglycerides are extremely high, then probably you need to have a bit of a more strategy, including people have used apheresis and hemofiltration. Even though the benefits are unproven, but people do have used insulin, apheresis, or hemofiltration in extreme case of the hypertriglyceridemia. If the disease is severe, then this patient needs to be shifted to ICU. Don't try to be hero and don't try to put them in the ward, because if they deteriorate so fast, they will get into a multi-organ failure by the time you have gone in the evening, and by the morning when you reach, you would be sitting with a multi-organ failure. Again, as fluid resuscitation forms a cornerstone in this, different strategies tailored to the patient is required, and usually large volume IV fluid is required. People who would require high or the risk factors for high fluid sequestration in the body would be younger age, alcohol etiology, high hematocrit, high serum glucose, SIRS in first 48 hours. ICU is required for the hemodynamic monitoring, CVP, and the blood gases. Along with the ICU care, you need to have and supportive measures like calcium for the hypocalcemia treated with calcium gluconate. Sometimes hypoalbuminemia is there. Albumin will act as a good colloid to keep the intravascular volume bit higher, but it will also seep out eventually. Support of the vasoactive drugs, noradrenaline, vasopressin, is required to keep the mean arterial pressure and the kidney perfusion. Now, nutrition is a very challenging, especially in the severe diseases. It is easier to start him if there is an acute severe disease with multi-organ failure. It is appropriate to start the parenteral nutrition. However, um, the current guideline says to start the oral feed, oral in the sense nasogastric feed, as early as possible. Now, there was a time where post-pyloric nasojejunal tube was inserted, and it was understood that giving this kind of feed will give rest to the pancreas. However, studies have shown that there is no difference in the mortality or the ICU length of stay if the patient is getting a nasogastric feed or nasojejunal feed. So, try or prefer early or as soon as possible um, starting of the feed. You can, what we call it as a trickle feed, maybe 10 or 20 ml an hour, just to make sure to keep the gut going. However, be careful, and if the patient is in severe shock with high vasopressor requirement and multi-organ failure, it is appropriate to start on the parenteral nutrition early. Routine prophylactic antibiotic has not been recommended. The only antibiotic which has been recommended in case you feel it is an infective in origin or there is a development of abscess, or if at all, are the carbapenems. The carbapenem, especially the imipenem or the meropenem. And usually I reserve these antibiotics to a bit of a later stage, because these are the one which has got a very good penetration inside the abdomen. So I will reserve them for the infected necrotizing pancreatitis or infected abscess. So this is just a cartoon which is just showing an overall view of fluid management as far as acute pancreatitis is concerned. It is the corner. Remember, it is a cornerstone. Overhydrating, overloading the fluid versus underfilling the patient with the fluid. It's a very tricky affair. Sometimes you have to give fluids, and then you have to fill him up one, and then you might have to remove the fluids and again give the fluids. The 2 and 4 things will keep happening, but you have to take it every shift by shift, hour by hour. You have to closely monitor how his intravascular compartment is there, how the perfusion pressure is there, and how her organ perfusion is there. So in acute pancreatitis, during the admission, look for the hypovolemia like dehydration, hypoperfusion. Take any strategy of fluid management, give 10 ml per kilo or 30 ml per kilo, give him a bolus, put him on the monitor, look for the signs of adequate intravascular volume status, and then move ahead whether to give further fluids or not. Remember, first couple of days, the inflammation will keep going, the fluid requirement go up and down. It doesn't mean that fluid resuscitation has to happen only during first 24 hours. There may be change in strategies, change in the pathology, and then you might have to revisit and start again the fluid resuscitation. There are nothing much as an adjunctive therapy. See, acute pancreatitis, mainly you have to wait and watch. You have to wait for the pancreas, which have got inflamed, to settle down. Once the inflammation settles down, things will settle down. At the same time, you also have to look for what was a trigger for this acute inflammation. Whether some of these triggers are reversible, some of them are not. If you know that there is a big stone sitting at the bottom of the common bile duct, there is a dilated common bile duct, and there is a big gallbladder sitting there, then you know that this has to be an ERCP and remove the stone. Otherwise, the pancreas will never improve. There are other, if there is an infection or anything going on, you have to give an early antibiotic is going on. Any other reason which you can remove that would have triggered, you have to look for and immediately apply it. While you are treating this acute pancreatitis, also, as I mentioned, these acute pancreatitis end up with so much of necrosis and may have a secondary complications, which commonly includes pancreatic necrosis, pancreatic abscess, and pancreatic pseudocysts. Hello, am I audible?
Yes, sir. You
Hello?
please continue.
Yeah.
Yes, sir.
Okay.
Please.
Right. So, so the treatment of the complication, mainly if there is a development of any abscess or there is a collection. Now, when it becomes a collection, then the whole drama starts. The whole fighting starts. One will say this is just a collection. The other will say this is an sterile inflammation. A third one will say it is just a pseudosis. Fourth one says it's just a necrosis. And fifth one will say it's an abscess. And unless you have a microbiological documentation by the fluid aspirated, you cannot say whether this is an inflammation or non-inflammation. There are only three things that will be debated. One, to give antibiotics or not. More than often, everybody it's easy and everybody will give antibiotics. The main thing will be between whether to call a surgeon or whether to call an intervention radiologist. Remember, an inflamed acute pancreatitis is a nightmare for surgeon. If a surgeon opens, he will not be able to close it. So most of the time, the surgeon, unless there is an obvious thing going on, he is not going to go in. So don't force him, because that mortality becomes very high if there is a mess inside. Try to conservatively do it as much as possible. Use intervention radiologies, put in the drains and try to drain the thing as much as possible. Surgeon's role comes early if your diagnosis is in doubt, whether you are thinking that differential diagnosis is peptic ulcer, it's a perforated peritonitis and all those things. Then the early involvement of surgeon comes in. A cholecystectomy or early drainage of bile from inflamed gallbladder, that would come with the intervention radiologist. In all these things, MRCP might be helpful. Necrosectomy and the drainage procedure, as I said just now, it is a very challenging. Necrosectomy may improve the survival in necrotizing pancreatitis with deterioration, but what time should the surgeon go in becomes a very debatable thing, and depending upon the surgeon's experience also. So be very careful. If the surgeon is uncomfortable in that, just take a second or third opinion. However, this is definitely an option if there is a territorial established sign that it is a complete necrosis. There is a huge whole of the pancreas is necrosed, and necrosectomy will definitely be helpful. The surgeon just chops up all the necrosed pancreas, and then it prevents the SIRC response. It just cuts the vicious cycle of the inflammation and prevents the multi-organ failure. Sometimes they do it what we call it as a step-up approach. So they go through endoscope with a transluminal or percutaneous drainage, and then once the inflammation bit settles down, it goes. Remember, it's not easy to pancreatic surgeries are not easy. First of all, they are the retroperitoneal. They have to remove complete all the organ things, and they have to go retroperitoneally. And second thing, it's all fluidy. It is like a jelly thing. So if you try to remove it, you may not be able to remove it. So try to understand their aspect also. They are not avoiding because they don't want to do it. It is extremely difficult and extremely dangerous also. Draining, try to drain if if possible, sometimes you just have to put in a drain and come out. Some surgeons do the flushing of the drains to get rid of all the necrotic thing, but remember, it has to happen in a very, very sterile manner.
ക്ലാസ്സിലെ പപ്പ ചോദിക്കും.
If pancreatic abscess is developed, then the surgeon will be very happy. He will require then the radiologist and the surgeon will be fighting among themselves that okay, I will go, because it becomes very easy for them. It is a very well content, well circumscribed, so they will go, they will remove the abscess and the things will settle down. If there is a pseudocyst, again, don't be in a hurry to go and open it up. Just the chronic pseudocyst is that it will stay there if it's sterile, unless it's causing symptoms or you feel that it is getting secondary infected. Then only people will go and drain it and improve the outcome. And all these things would definitely improve the outcome. If it's an infective etiology and you're very sure shot, or even an empirically, drug of choice are carbapenems. Ideally, it's an imipenem 500 milligram TID, but you can go for meropenem also. There are a few centers, especially high-end centers, where piperacillin tazobactam or third or fourth generation cephalosporins have been used. However, most of the books do recommend only the carbapenems. Pancreatic duct leaks and the fistulas, which are again the complications, would require a high-end endoscopic surgery, and these are extremely specialized surgical things and happens mainly in the specialized surgical centers who are dealing with this kind of microsurgeries. Chronic disconnected pancreatic duct syndrome, again, because this is the situation where the ducts are burned out and the pipes are broken and they are leaking. Again, they require an extremely specialized gastrosurgeon. How's the prognosis? So, as compared to previously, definitely the mortality has improved. I mean, just especially even for the mild pancreatitis, and I think it is mainly because of the appropriate fluid management and intensive care support which these people have started getting now. Acute severe pancreatitis mortality still remains high. Having said that, overall mortality, initially it used to be 40-50%, has come down to almost 20%. If there is a sterile necrosis, still you have 10%, and if it's infected, it's a 25%. If multi-organ systems are involved, if it's a transient response, the mortality is low. But if it's a persistent inflammatory response and the patient is going towards multi-organ, again, the mortality remains high. However, with a good ICU care and support, these things can still be achievable or manageable. If your patient with acute pancreatitis has an early death, then it especially within first 2 weeks, then it is most commonly because of the multi-organ failure. Mortality with multi-organ failure is more than 30%, and if there is renal involvement, they say that it will almost shoot up to more than 50%.
Any aspirants have any question they may ask now?
The late death, if you are looking at, would be mainly as a complication of the infected necrosis or infection of the complication of the acute severe pancreatitis. Again, these people tend to stay long in the hospital, so we have to be very careful with the hospital acquired infection as it increases the mortality. If you are discharging this patient, then there are few risk factors which can cause readmission. Readmission within 30 days is predicted by if the patient is been discharged, he's still not eating well, he's still got pain, nausea, vomiting, patient has still got a bit of a necrosis, the pain continue to be discharged, then these patients are likely to come back, especially if they are male sex, having alcohol as etiology, and severe initial acute pancreatitis. Alcohol-associated pancreatitis and recurrence is very high, and especially if the patient is smoking along with the alcohol, then again the chances that they will have recurrent pancreatitis and recurrent admission is very high. The risk of the long-term problems is as follows. So, with every year passing, the chances with chronic pancreatitis increases. The risk is almost double over 5 years of development of diabetes mellitus, and almost 35% of people will have recurrent pancreatitis and may develop a chronic pancreatitis. Again, alcohol and smoking are the risk factors. Now, it is not common to have a pancreatic cancer after an acute attack of pancreatitis. However, if the acute pancreatitis has turned into chronic pancreatitis, then the chances of getting pancreatic cancer is increased. Almost all the patient needs to be admitted, and consider early ICU admission if any of the organ failure or high risk you are thinking. Please take help of the ICU. So that's about the acute pancreatitis. Any questions? I know it's 1 hour above, but any questions? Should we move to chronic pancreatitis?
Sure, sir.
Right. As against the chronic acute pancreatitis, which has got a lot of drama and which is a very action-packed when the patient comes, the chronic pancreatitis is more of a challenge and a patience, because these people you cannot reverse the pancreatic issues, and they have this chronic problem of chronic pain, indigestion, flatulence, weight loss. It's a very, very sad thing for those people with the chronic pancreatitis. Life is not easy. Chronic pancreatitis happen with as persistent inflammation and causing the irreversible damage. As with the acute pancreatitis, chronic pancreatitis, alcoholism is a common and responsible for almost 80% of the cases. Along with that, add tobacco smoking, hyperparathyroidism are the one. Tropical pancreatitis in Africa and Asia are the one which goes unnoticed. These are the people from lower socioeconomic class, and they have this vague abdominal discomfort and end up with a slow burning pancreatitis leading to chronic pancreatitis symptoms. In West, obesity with pancreatic stenosis increases the risk of pancreatic insufficiency and cancer, which I think is also relevant to our Indian population. There is an entity called as autoimmune pancreatitis, which is again type 1 and type 2, where it is IgG4 related, and which is mainly seen in the elderly people. And there is an idiopathic duct-centric pancreatitis, which only pancreas only involvement are there. And again, it is an autoimmune in nature. Sometimes a chronic stricture, stone, or a tumor may lead to a chronic pancreatitis, especially at the ampulla of Walter, or some duodenal issues may end up with a chronic pancreatitis because it's a slow way. Few genetic diseases would cause a chronic pancreatitis. If it's an early onset with a median age of 20, there is a 50% link to genetic mutation. If it's a late onset, again, it's a 25%. Other diseases like cystic fibrosis are there, and other genes which we can see on the screen have been contributing to the known to contribute for the chronic pancreatitis. Two mutations, PRSS1 and which is an autosomal dominant, one mutation, sorry, the PRSS1 mutation is responsible for what we call it as a hereditary pancreatitis. There are few predisposing factors which can be remembered with the mnemonics, with the toxic metabolite, idiopathic, genetic, autoimmune, recurrent and obstructive. Remember, these are the chronic pancreatitis. These are the people who will be coming not as an acute or maybe an acute attack on the chronic one, but mainly they will be having a long indolent course. If you're sitting in an outpatient, then probably you will have to have a very low threshold to diagnose this, because these people will come in with a very vague symptoms. The pathogenesis, a SAP hypothesis has been proposed, where they say that either it starts with an acute pancreatitis event, where there is an initial acute pancreatitis will cause an inflammation and fibrosis, and it results in a chronic inflammation, necrosis, and healing by fibrosis. Natural history wise, these patients have got a very vague presentations. Either it's a chronic pain, or they might be coming with acute recurrent pancreatitis. They will have exocrine and endocrine pancreatic insufficiency over the time, and more than 80% of them will develop diabetes as a part of their uh, uh, chronic pancreatitis. Sign and symptoms, there will be persistent or recurrent epigastric pain or the left upper quadrant pain with anorexia, nausea, vomiting, constipation, flatulence, weight loss unexplained, and burping are the red flags which you should start thinking about the pancreas. The physical finding may be completely normal, or it may be with the pancreatic tenderness or muscle guarding. They may or may not have ileus. The pain would be either indolent. It may start with a few hours to a couple of weeks, but they may have a continuous pain, and they said it's been there for long. Late in the course, they may complain, not in the early, but late in the course, they may complain of steatorrhea as a bulky, foul, fatty, light color stools. Now, laboratory finding again are more tricky as compared to acute pancreatitis. The amylase lipase may be normal or maybe get elevated during an acute attack. If there is an alkaline phosphatase and bilirubin is elevated, then you have to think of the biliary causes, biliary strictures as a cause for the secondary pancreatitis and chronicity for that. Glycosuria, excessive fecal fat may be present, so the stool examination becomes an important here. Sometimes, as a therapeutic thing, you might have to give pancreatic enzyme therapy, and if the symptoms go away and the fecal fat go away, then probably you're dealing with a chronic pancreatitis. Patient may not have anything else, just a vague abdominal pain. There is something called a secretin stimulation test, and fecal chymotrypsin detection is there. We'll see it later. In case if you're suspecting autoimmune pancreatitis, then autoimmune markers can be sent, or if you're strongly suspecting genetic involvement, then genetic testing could be sent. Imaging study, again, here also the imaging study play a very, very important role. I have seen a lot of tropical pancreatitis is seen just on the plain abdominal X-ray. You would see in a classic pearl string appearance on the X-ray, but it may or may not be always be there. CT scan again comes to our rescue with the calcification, ductal dilatation, gland atrophy can be clearly seen, and similarly MRI will see with a better resolution. ERCP is most sensitive for chronic pancreatitis, showing ductal changes, but it is rarely used. And again, autoimmune pancreatic imaging you can see as the diffuse pancreatic enlargement, hypoattenuation rim, and ductal irregularity. Now, you don't diagnose chronic pancreatitis based on an endoscopic ultrasound, but if your CT or MRI is not conclusive, then you can do an endoscopic ultrasound, and there is a Rosemond criteria for that, where you see an hyperechoic foci, ductal calculi, lobularity, honeycombing. as diagnostic for the chronic pancreatitis. During the same ultrasound, you also do a biopsy and histologically, which becomes a gold standard when imaging is non-conclusive. Autoimmune pancreatitis, again, you need to have an Ig4 staining and lymphoplasmacytic infiltrate, which you will be seeing on the biopsy or histology. The complications of the chronic pancreatitis are not as dramatic as you can think of in acute pancreatitis. Here, there is a chronic indolent pain, which is relieved with morphine or opioids or tramadol, and they become an opioid addict. Diabetes is another complication. Sometimes pancreatic cirrhosis or abscesses, which, if at all, this is a part of chronic pancreatitis or recurrent pancreatitis. Bile duct stricture as a cause, cholestatic liver enzyme, exocrine pancreatic insufficiency, malnutrition, malabsorption, osteoporosis are the one. Peptic ulcer, peptic ulcer bleeding, perforation, again become an important when you're dealing with it may be a chronic pancreatitis might be a cause for these things. 5% of the patients develop pancreatic cancer even after 20 years. And in hereditary pancreatitis, almost 20% of the pancreatic cancer by the age of 70. So you have to also, if you're following up with somebody with a chronic pancreatitis, keep this thing in mind. For the diagnosis of autoimmune pancreatitis, in the US, they have given what we call the HISOT criteria, where they use the histology, imaging, serology, and other organ involvement and respond to corticosteroid therapy for the autoimmune pancreatitis. Again, management is mainly the medical. There are very few indications for the surgery, or rather no indication for the surgery. Because it's going to be a chronic indolent course, low-fat diet, you have to ask them to stop alcohol, stop smoking. Pain management is extremely challenging in this because the opioids will still be the best, but if they have become an addicted, then it becomes very hard to know whether they are like drug seekers or whether they really have pain. So it becomes a challenging. You can try using acetaminophen, NSAID, tramadol alternatively, but eventually you end up giving opioids only. But you have to follow these patients up. Sometimes antipsychotics like pain modifying agents like tricyclic antidepressant, SSRIs, gabapentin can be used. These patients will surely require pancreatic enzyme replacement therapy, and it ranges from 40,000 to 90,000 units based on the lipase. And in addition to that, you can have a bit of an acid suppression, which H2 receptor antagonist or PPI, and that enhances the effect. If autoimmune pancreatitis is confirmed, then you have to suppress the immunity. So you have a prednisolone can be given. And if it is refractory to steroids, then rituximab or azathromycin. Thiopurine is the drug of choice. There are very limited scope for endoscopies and surgical treatment here. And again, if it's a secondary chronic pancreatitis because of the biliary tract disease, or you're dealing with a pseudocyst or obstruction, then you have endoscopic placement of the stents or lithotripsy of the stones useful. There are a few surgeries for the pancreatic necrotic or necrosectomy or pancreatectomy or auto. Now we have islet auto transplantation as a surgical indication or the surgeons to get involved. Sometimes as a part of the pain management, celiac plexus nerve block or the irradiation for the refractory pain, because this pain is very, very annoying and a lot of people may end up with a suicide because of that pain. So celiac plexus nerve block is one of the surgical techniques where you can go inside and block it for the pain management. Prognosis wise, chronic pancreatitis often leads to more of a disability and reduced life expectancy because they they are really in a bad shape. They cannot eat. They are constantly in pain. They are opioid dependent. They are every meal they have to take pancreatic enzymes. It becomes a very bad quality of life. Again, if the chronic pancreatitis develop into a pancreatic cancer, then it becomes again a leading cause of death. Addiction to the opioid is again common with the refractory cases. Most of the time, these patients are managed on the outpatient basis, requires a lot of psychological support, requires a lot of psychiatric inputs, and a pain management team. Pain specialists need to be involved for these patients. There's nothing dramatic unless you're looking at a pancreatic transplant. That would be that again still has got a limited access, but the success rate is still not as great as the other surgeries. So you might have to admit the patient if there is a severe pain or there is a new onset jaundice or a secondary infection or a new fever. So that's about the chronic pancreatitis.
Excuse me, sir.
Yes.
Can you
Ishan,
please repeat the HISOT criteria once more? I just missed
HISOT
it.
criteria. Okay. So HISOT criteria is, look, it's basically the diagnosis of autoimmune pancreatitis based on the histology, imaging, serology, other organ involvement, and response to corticotherapy. They are just put in a mnemonic, but honestly, I don't think this as a criteria. Histologically, you will, as I said, IG4 staining and lymphoplasmacytic infiltrate will be there. Then you have imaging. On imaging, you see chronic pancreatic features, calcification, ductal dilation, gland atrophy. Then we have third is a serology. So you have an autoimmune serology, which you have seen during initial thing. Elevated IgA, ANA, anti-lactoferritin, anti-carbonic acid thing, and other organ involvement are there or not. Most of the time, it is a pancreas only involvement, so other organs are not involved. And then you give them a steroid, and then if they recover, then it becomes an autoimmune pancreatitis. Am I clear?
Yes, sir. Thank you, sir.
Anything else?
Any more questions? I guess there is no question for now, but if any question occurs, I'll be scheduling a session with you, okay?
Okay, that would
Thank
be
you,
good.
sir.
Thank you very much. Thank you
Thank you.
all.